السلام. واضح دكتور.
السلام ورحمة الله وبركاته. واضح الصوت.
Our topic today is acute scrotum. Of course, when we say acute scrotum, we don't mean traumatic cases. So our topic today will be exclusively non-traumatic acute scrotal cases. Cases that you might see as outpatient or in the emergency department. So acute scrotum is an emergency situation that requires prompt evaluation, differential diagnosis, and potentially immediate surgical exploration. Differentials of acute scrotum. As you can see, there is a long list. Most importantly, in acute scrotum is to rule out testicular torsion or tumors. Other cases are cold cases. Sometimes they might present to ER. Patient was unaware, and suddenly when he's aware of it, he will come to the emergency department. But in any patient with acute scrotal pain, you have to rule out testicular torsion. That's the most important. Secondarily, tumors. So for differential diagnosis, acute scrotal pain. When we say acute, it's days, hours to days, sometimes a week if the patient neglect the pain and wait. But usually they present, if it's torsion, they will present in hours. If it's epididymitis or infection, epididymorchitis or orchitis, which is the most common, they will present from hours to a week. Same thing for tumors. So, general rule for any patient with scrotal pain, even if you think it's silly or chronic pain, you have to rule out testicular tumor. So what happens during torsion? As you can see, when there is torsion, the testis will be torted around its vessels, which will result in ischemia, depending on the degree of torsion. Sometimes it's 180, sometimes it's 360, sometimes it's more. As you can see here in A, it's almost 3 times torted around itself. So the more severe the torsion, the more ischemic changes happens, and the less time you have to intervene. As you all know, there is extravaginal and intravaginal torsion. Do you know what's the difference between them? So, one case happens in pediatric cases when it's undeveloped, the scrotum and the layers, especially the gubernaculum. Gubernaculum is the muscle holding the testis to the scrotal wall, and it controls it to keep it attached to the testis, to the scrotal wall. So it doesn't go up, it doesn't rotate. Sometimes it's malformed, and that's especially in pediatric cases. So in torsion in the pediatric cases, the whole sac is torted. But in adults, only the testis is torted. That's the main difference. So when we say torsion of spermatic cord or testicular torsion, it's a surgical emergency with the highest order. Irreversible ischemic changes happens as soon as 4 hours. So you have to intervene before it reaches that time. Every minute's count. Testicular salvage decrease as the time goes by. So delaying the intervention for ultrasound or for further assessment or any delays will compromise the testicular tissue. Any tissue lost during torsion will not come back again, and you might lose the whole testis and get the patient infertile. So it's extremely important to see the patient, diagnose him, as soon as possible in the emergency, and if there is any delay due to ultrasound not available to confirm the diagnosis, you take the patient immediately to the operating room for exploration. It's a purely clinical diagnosis, and it shouldn't be delayed for ultrasound. So for testicular torsion, they present with acute onset of scrotal pains within hours. It's a very severe pain, most likely accompanied by nausea and vomiting, severe pain from the scrotum up to the abdomen. Majority of the patients, as we mentioned, there is malformation of the attachments of the testis, so they will have previous episodes of similar attacks, or at least temporary torsion. It will be severe, self-limited scrotal pain and swelling. Swelling happens due to the when the patient having ischemia due to the torsion. There will be a collection of fluid secondary to that ischemia and inflammation. As we mentioned, they will present with severe pain, nausea and vomiting, high riding testis, because when the testis is torted, as you can see, it goes up. The more severe, the more you will find it up. Sometimes you will find it in the upper scrotum or even in the inguinal canal. So the pain will be referred to the ipsilateral lower quadrant of the abdomen. Sometimes the patient might have even dysuria and other urinary symptoms, but they are not the main symptoms. So for physical examination, here is the tricky part. It's important to differentiate between torsion and other inflammatory acute onset diseases or differentials. So both patients with torsion and epididymorchitis might have swelling. They might have hydrocele, as you can see in this patient, and sometimes it's difficult to examine the patient if the hydrocele is severe. So the affected testis will be high riding, and it will not be in the normal position. So always, for any patient, for any examination, not testicular examination, limb examination, eye examination, always you start with the normal side. You examine the normal side first, you establish what's normal for this patient, then you go to examine what's abnormal for any examination. So as for this patient, you will examine the normal testis. You will find it normal lying in its normal position. Then you will compare to the other side. You will see there is acute swelling, hydrocele. By the examination, you will recognize it. Also, you will see the testis is lying transverse. What does it mean? The normal testis في الفحص الطبيعي بتشوفها بالطول واقفة. When there is torsion, بتكون بالعرض transverse. It will be high riding. So when you examine here, you will not find it similar examination like this one. You will find it transverse and high riding. There will be sometimes, not all the times, don't expect hydrocele to be there all the times. Sometimes it will have acute hydrocele or acute scrotal edema, massive edema. So what helps you to differentiate between epididymorchitis and torsion? In the epididymorchitis, the testis will be in the normal position. In the torsion, it will be high riding. Also, in the torsion, when you stimulate the cremasteric reflex, it will be absent. In the epididymorchitis, it will be there. How do you stimulate the cremasteric reflex? So to stimulate the cremasteric reflex, gentle palpation here in the inner thigh should stimulate the testis to go up. This is stimulation of the cremasteric reflex. It's not always present, but when it's present, it helps you to differentiate between the two. So passing your finger gently on the skin in the inner thigh on the same side, in the normal testis, it should go up, providing that the patient is relaxed and not tense. Also in the examination, you will feel tender and larger than normal side. This can happen also in orchitis. So also you will have negative Berhen sign. So what's Berhen sign? Berhen sign is when you elevate the testis, the pain will get better. So if the pain doesn't get better, this is negative sign and goes more in favor of torsion of the cord. So manual detorsion, this can temporarily restore the blood supply to the testis, but it's not a treatment. So as we mentioned, negative Berhen sign when there is no pain relief with lifting the affected testis. When there is pain relief, that goes more in the favor of epididymorchitis. So there is other tests to aid in the differential, but you shouldn't, as we mentioned, and we will mention 20-30 times, you shouldn't delay your intervention waiting for imaging or adjuvant tests. So if it's available and it will not delay and affect your management, you can use other tests to confirm your diagnosis. So color Doppler is the gold standard. You will establish if there is blood flow to the testis or not. It helps you assess the anatomy, and it's highly specific but operator dependent. Here we can see this is the testicular artery and there is good blood flow. But you can see when we assess for the pulse, it's important to see the pulsatile. You see the testis here, there is no flow. So this will help you differentiate between the two. So here we see that the flow, there is good flow, but it's stopped. There is no flow reaching the testis. This is in the color Doppler. It will give you the waves, pulsatile waves of the artery. As you can see, it's absent here. So other tests, this is not readily available, not in every hospital, and it's time consuming. It confirms the diagnosis, but we never used it, and it will never be used. It's expensive, but it's for theoretical and research purposes. So radionucleotide, it will assess the blood flow comparing to the other tests. Similar sensitivity to the ultrasound, but lower specificity. Why it's less sensitive and less specific? Because of the hyperemia of the scrotal wall. So whenever there is inflammation, there will be a false negative, and that will give us, you will think there is blood flow, but this is from the wall, hyperemia, and could be from the inflammation and irritation of the scrotal wall. So this is the radionucleotide. As you can see, the blood flow comparing the two tests. So most importantly, when the patient presents, if you have high degree of suspicion there is torsion, you will take him for OR without any delays. If he's presenting in the first hour, or if you think that the patient is not having torsion and you want to confirm your diagnosis. So ultrasound, you will use it to confirm that he's not having torsion. Whenever you think there is torsion, you will take him directly to OR. But let's say this patient is having the pain for 1 day or 2 days, and you are suspecting torsion, but the history gives you more in the favor of epididymorchitis, then you can go for ultrasound to confirm before discharging the patient that he's really having epididymorchitis, not torsion. But if the patient is presenting with pain for 5 days, 1 week, then there is no rule to rule out torsion. Torsion will present in the first hours. So surgical exploration, you will make a scrotal incision, either transverse or median raphe. So median raphe, you will take. So this is the median raphe. So when you are planning to explore the testis and fix the other one. So whenever there is torsion in one testis, we prefer to fix the other one to avoid torsion in the other one in the future. So if we are planning to do that, you will do a median raphe incision, so you have access to both testes, because there is median raphe that split the testis scrotal content. It's completely separate. So either you open in the median raphe or you have to make 2 separate openings. If you are planning for separate opening for the exploration, then you will have transverse incision. So you start by exploring the affected site. You explore for it. You will examine under anesthesia, and then you will make your incision, explore the testis. Is it viable or not? Once you establish that there is ischemia, you try to detort the testis, return it to the normal anatomical position, and wait and rub the testis in a warm gauze, as you can see here. So this is after exploration. This is the testis, torted testis with a compromised blood supply. You will wrap it in a warm gauze or towel and wait for a few minutes to reassess the blood flow. But what if the testis is like this? As you can see here, the cord is inflamed and there is it was a severe torsion. This testis is gone, so we cannot salvage this testis. It has to be removed. But for this one, it has good prognosis. If you wait for a few minutes, the blood supply will go back. So as we said, we will examine the affected site first. Then we'll do a detorsion, restore the testis to a normal anatomical position, wait for a few minutes, and wrap it in warm gauze and reassess the viability. If it's viable, then we will fix it in the normal anatomical position and we will fix the other side. If it's not viable, like this one, then we will remove the whole testis with the cord and fix the other side. So you will make a dartus pouch to fix this testis in the normal. The dartus is the layer between the scrotal wall and the testis. It's a muscular layer. We will make a pouch, a pocket, connect to جيب يعني, and you will fix the testis in it. The contralateral testis must be fixed to avoid torsion in the future, because the patient now has only one testis. You will have to protect that testis. So we'll fix it to avoid, because if you have torsion in one testis, most likely you are more prone to have another torsion in the other testis than the normal population. So as we mentioned, for patient presenting with acute scrotal pain, is it short duration or long duration? This is the most important question. So if it's short duration and there is no sign of urinary tract infection, the examination is in favor of torsion, you will go directly to OR for surgical exploration. As we mentioned, you only have 4 hours of torsion. More than that, then the testis is gone. Even if there is a salvage of the testis and you were able to restore the blood supply, most of the tissue will not be viable. So you are affecting the patient's future in terms of fertility. He will not be able to have kids. Also in terms of testosterone secretion and by the testis. So it will affect fertility, it will affect testosterone level in the body. Testosterone is very important for libido, for maturation, for muscle mass, for cognitive function, for bone density. It's important for every tissue in your body. So it's very important hormone and you must preserve it. So short duration and the symptoms, as we discussed, is in favor of testicular torsion. As you see here, high probability. You don't have to be sure it's torsion to take him to OR. Whenever in suspicion, you take him for exploration. But what if it's long duration? Or if the patient is having urine analysis positive for infection? If the patient coming with a few days, 5, 4, or 1 week history of scrotal pain, acute, still acute, but now it's not in favor of torsion. So it's low probability of torsion. Then, as we mentioned, you have to do color Doppler ultrasonography. Why? First, to confirm your diagnosis. Second, to rule out tumors. So even if you have 1% suspicion that there is torsion, you have to confirm. But when this suspicion is high, more than 50%, you will go directly to OR. So as you can see here, I'm not suspecting torsion. It's not in my differentials list, but I have to confirm. Because some patients will come very late. Some patients will neglect the pain. They will think it's related to trauma. They will think it's related to any other thing. So you have to confirm before discharging the patient. How do we confirm? With color Doppler ultrasonography. So if we see decreased or absent blood flow, that means it's torsion. Or if the results is not confirmed, it's equivocal, the radiologist is not confident in that there is good blood supply, also you will have to go for OR. So even with equivalent results, you will have to go to OR. You will have to explore and confirm that the testis is viable and there is no compromise to the blood supply. But if there is increased or normal blood flow, then most likely it's a non-operative management of infection, epididymoarchitis. So to summarize, if there is high suspicion, you will go directly to OR, you will not wait for ultrasound. If there is low chance that it's torsion, we have to confirm. Why is the patient having pain? Is it tumor? Is it missed torsion? Is it epididymoarchitis? Even if the patient is presenting after a few days, if he neglected the pain and the swelling, even if there is no flow in the testis, you will have to go and take it out, because if you leave it, it will result in necrosis and in abscess formation, which might complicate the patient condition. He will come with sepsis or even infection of the other testis. So even if it's past the window of saving, you have to take it out and examine it. So the only way to discharge the patient is to confirm by ultrasound there is normal or increased blood flow. So the other emergency presentation of acute scrotum is epididymoarchitis. In these cases, the patient will present with scrotal swelling, erythema, and pain. Sometimes they will have dysuria or fever, but not all the times. Why dysuria? Because most of the inflammation and infection of the testis comes from urinary tract. In the young age, it's sexually transmitted. In the old age, it's related to the urinary tract infections. It's an ascending infection. So it doesn't directly go to the testis, it goes through the urinary tract. That's why for every patient we have to do urine analysis to confirm there is no UTI. Fevers, when the patient is having fever, that means systematic involvement. So the patient will present with acute pain, sometimes a week, 10 days, and sometimes within few hours of pain. You will examine, you will see that there is tenderness, severe tenderness. When you examine a patient with torsion or with epididymoarchitis, whenever you touch the testis or even the scrotal wall, the patient will jump. You will find swollen and tender epididymis or testis, or both. Sometimes there is severe hydrocele, you cannot even examine the testis. In these cases, the ultrasound is helpful. You will see massively swollen hemiscrotum. There is no landmark. You cannot reach for the testis because of the tense scrotal wall due to the swelling. In this patient, cremasteric reflex should be present. As we mentioned, even in these cases, sometimes you will examine the patient is in pain and he's tense. So whenever the patient is tense and not relaxed, you cannot have normal reflexes. In the urine test, you will have either sterile pyuria. Sterile pyuria means there is white blood cells in the urine, but there is no infection. There is no bacteria. You will only have white blood cells. You might have bacteria in the urine analysis. Of course, positive urine culture will take 3 days, 2 to 3 days, and that will be most likely gram-negative bacteria from the urinary tract. So when we confirm that it's epididymoarchitis, you have to be sure either the patient is presenting with a long history, 1 week, or you did ultrasound and you confirm that it's for sure epididymoarchitis. I've seen many cases go to court due to this. You are confident that it's epididymoarchitis, you did not confirm with ultrasound, and the patient later on find out that his testis is gone, and he will see you in court. So when you establish that it's epididymoarchitis, either you are sure 100% from the examination, the scrotal is lying in the normal position, there is positive burn sign, and there is a positive cremasteric reflex, and you confirm with ultrasound, then you can discharge the patient. Most cases of epididymoarchitis can be managed as an outpatient, except the cases when there is systematic involvement, when the patient is febrile and septic. So most patients are not. So we'll advise them for bed rest, 1 to 3 days, and avoid any scrotal trauma. Scrotal elevation helps. We have an underwear that garment can be worn. It's called scrotal support, or any tight underwear can be used, like the athletic supporter. Also, if the patient is febrile, we will give them parenteral antibiotics, IV antibiotics, until the patient is non-febrile. Then he can be discharged on oral medication. If it's UTI the source, that means, and the patient is febrile, that means it's systematic. The patient is septic. You will have to give IV antibiotic and keep him for observation. You have to avoid any urethral instrumentation unless the patient is not able to empty his bladder. So this is important to differentiate between the presentation. So you will see an infection, the patient will have fever, and the torsion he might not. But even if the patient is presenting with fever, sometimes even patients with torsion present with fever. Torsion of the testicular appendages is it will present like testicular torsion, but it does not have the same severity. So you will have to confirm that there is blood flow to the testis, or in the exploration you will find normal testis with the testicular appendages ischemic. So it has no role and there is no harm. If you lose it, it will not affect your fertility. So testicular appendages, it's similar to the appendix. زيها زي الزايدة. Even if you lost it, there is no complications. You will see if the patient is light colored skin. If he's having light colored skin, you will have a blue dot sign and very localized tenderness to the anterior of the testis. For other presentations, sometimes patients will present with, after trauma, they will present with long-standing swelling they just discovered and they are anxious, and sometimes they will present with tumors. So for any patient presenting with scrotal pain, either in the clinic or in the ER, you will have to examine the patient and never discharge the patient without ultrasound. If the patient doesn't have acute symptoms, you have to give him ultrasound with follow-up within few days. If the patient had testicular tumor and you missed it in the examination, or you gave them a routine follow-up with ultrasound after a few weeks or few months, this can change the patient's life. Testicular tumor can double in size in a few weeks and can change in the stage of the tumor. He might present with stage 1, and you give him follow-up after 3 weeks, he will present with tumor metastasis. So it's very important for every patient coming with testicular pain, either in outpatient clinic or in the ER, to examine him, to give him, to confirm your examination with ultrasound, to rule out torsion, testicular tumors. Otherwise, you will be liable if the patient had any of these and you missed it. Other conditions are cold. Hydrocele, varicocele are all cold cases that can be confirmed. When you examine the patient, there is no pain and the testicular is in normal position. Then you can confirm with ultrasound. There is no tumor. Patient can go. It's a cold case and doesn't require urgent management. Sometimes patients with hernia, inguinal hernia, they will present with testicular swelling, and if the hernia is carcerated and there is inflammation, also you will have to differentiate. How you will differentiate between hernia and testicular torsion or orchitis in the examination? If the patient is having hernia, you cannot palpate the cord. But if the patient doesn't have hernia, you can palpate the cord. Any questions? Is one testis enough for fertility? Yes, providing that testis is normal. But how many patients have normal testis? You are not sure 100%. So you have to save what you can. But if the other testis is totally normal, yes, there is it's enough for fertility and testosterone secretion. Some patients are born with one testis. Any questions?
شكرا دكتور الله يعطيك العافية.
So take home message for any patient with scrotal pain, even if the pain is not acute, even if the patient is not in pain, whenever there is severe pain or there is a patient is feeling a mass in the testis, you will have to make sure 100% that the patient doesn't have tumor. Especially it's all in the same age. Testicular torsion, epididymoorchitis, and tumors is same risk in the same age. They all present in young age, young adulthood. So between the age of 15 to 30, sometimes even 35, the patient will present with mild pain. Sometimes they will present with acute swelling, Sometimes they might present with acute pain. Sometimes the patient might have trauma to the testis and present to the ER, and we find out that he has tumor. So whenever there is scrotal pain, you have to make sure if it's acute, if there is swelling, if the patient is severe pain, you have to rule out torsion. If it's cold case and the patient is only coming with mild pain, you will have to rule out testicular tumor. So this is take-home message. You have to keep it in mind always. بالتوفيق إن شاء الله.
دكتور محمد لو سمحت.
تفضل.
طال عمرك إذا ممكن بس ترسل لنا المحاضرة على الإيميل الدفعة إذا ممكن.
بنزلها في البلاك بورد. بالتوفيق إن شاء الله.